Hello, good evening, and welcome to this evening's Facebook Live session. My name is Alec O'Dare, and I'm the Managing Director of Wound Care People. I'd like to start by introducing our speakers and our session for this evening, which is called Transforming Wound Care, Simplifying Venous Leg Ulcer Management. And this evening, I'm very pleased to announce we've got back the wonderful Dr Caroline Dowsett, Nurse Consultant in Tissue Viability, and Jen Letchford, who's doing her very first Facebook Live, her first of what will become many, I'm sure. And Jen is a Tissue Viability Nurse Advisor. Jen, Caroline, are you there?
Yes, we're here. Pleasure to join you this evening.
Excellent. Jen, how are you?
I'm very well, thank you. Yes, yeah.
Excellent. And yourself, Caroline?
Yes, I'm good, thank you. Busy in the NHS, but I guess many of our viewers this evening are busy in the NHS, but still finding the time to join us this evening, which is fantastic.
Yeah, and on that, this is our final event for 2020. So a huge thank you from myself and my team for all of you who are joining us this evening, but equally for anybody that has joined us for more than one event. We know that lots of people join us for multiple events, so we're really pleased to be able to deliver these, and we've had a fantastic year despite the difficulties because of COVID. We found a new way to provide this education, and we wouldn't be able to. It wouldn't be any point in us doing it if we didn't have the wonderful audience that we often do. As well as the audience, I'd like to thank Coloplast, who are sponsoring this evening's session. They've done a number of events with us this year, so thank you very much to them. As always, certificates will be available at the end of the broadcast. The link will be displayed on the screen. You can see that, and I say this all the time, you can see that we're delivering this from our home, so if there's any technical issues, do bear with us. One of my colleagues will be answering questions through the, or making comments and responding to your questions through the chat box. Please do send through as many questions as you can, because we'll be coming back after the presentation for a live Q&A, as always. I think that's about it for now from a housekeeping point of view. So without further ado, I'm going to hand over to Jen, and I will see you ladies back after the presentation for the live Q&A. Good luck.
Thank you.
Thanks, Alec. Yes, so as Alec has mentioned, I'm Jen Letchford. I'm a Tissue Viability Nurse Advisor with Coloplast. I've only actually recently left the NHS back in March of this year, 2 weeks before the country went into lockdown. So I can really resonate with some of the issues that you might be having with your venous leg ulcer patients and the management of them. So tonight's session is transforming wound care and simplifying venous leg ulcer management. And I shall go on to some of our learning objectives for this evening. And we're going to be looking at why we need to transform wound care. Also, Dr Caroline Dowsett will be going into a bit more detail about the wound care journey, where we've come from and where we are now with our national lower limb management guidelines. We're going to be looking at supported patient self-management or shared care, and the opportunities for shared care and sharing best practice. And as part of that is the partnership working, not only between yourselves as clinicians and patients, but between possibly industry partners and the NHS. So looking at why we need to change, why we need to transform wound care. I know from my own practice that there was a reduction in district nurses and community nurses and even practice nurses actually. And that meant that there was an increased need to be able to manage these patients and see patients with wounds. But with a reduction of staffing and an increase in wound prevalence and people living with more complex needs and comorbidities, it's posed a real challenge to us. So we need to do something to try and change that. Which then, brings me on to a prediction really of Guest et al. Of a cost of 11% growth in wound management. And I'm really sure that our resources aren't growing at the same level. Again, I go back to my own practice. I certainly didn't see resources increasing by 11% annually. And by resources, I mean staffing really. There's that reduction in staffing, which meant a huge impact to services. And that has a knock-on effect to our patients and their quality of life. as well as the increased cost. So what I'd like to do here is really pass over to Caroline, who is going to go into some of the wound care journey, where we've come from, where we currently are, and really look at the national lower limb guidance to bring us up to date with those things. So Caroline, over to you.
Thank you very much, Jen. It's my pleasure to join you this evening for this event, and I'd like to thank the JCN and our kind sponsors, Coloplast, for the opportunity to join you and discuss how we can transform and simplify venous leg ulcer management. But I guess it's worth remembering what transformation means, and to transform practice, that means we need to do something different. And I really hope that our event this evening and our discussions that follow will prompt you to consider some opportunities for how we might work with patients to simplify their management when they have a venous leg ulcer. But I'd like to start by looking at some of the recent drivers for transformation in the care of patients with wounds, and in particular lower limb wounds. And I guess when we talk about change management, often the drive for change comes from the cost of care. And Jen already mentioned the Burden of Wounds publication from the Guest et al. Group, and there's been a number of publications that really highlight the cost of caring for patients with wounds. And the estimated annual cost is 5.3 billion, which is a considerable amount of money. And I think we have to remember that poor quality care costs more. So if we're not delivering evidence-based care for these patients, and for venous leg ulcer patients, that's compression therapy, then we prolong their episodes of care, and that in itself costs more. And the unwarranted variation in care in the health service was highlighted in the Lord Carter Review in 2016. And I think for many of us as clinicians, our starting point is often with the patient. And the NHS Right Care scenario talks about Betty's story, and that came out in 2017. And it talked about the difference between optimal care for Betty and suboptimal care. And I'll talk a little bit more about Betty's story. But I guess as a clinician, what I see is the human suffering for patients who have lower limb wounds. And I know that more can be done. And I think with that in mind, some of the drivers now, we have a sequence target, so a commissioning for quality improvement payment for lower limb wounds in the community. And many of you will have started in the delivery of that earlier this year, but it was put on hold because of the COVID-19 pandemic. But of course, we have to now revisit that in Q4 and start delivering on it. So there's a driver in respect of changing the way we deliver lower limb care. And then we have the National Wound Care Strategy, which I'm going to talk into, and we have our clinical work stream looking at lower limb wounds, and we've had recommendations recently. And within those recommendations, there is a drive to simplify wound care and to engage and involve patients more. So I think there's an opportunity here. Going back to Betty's story, and I think if we look at our caseloads, I know when I do caseload reviews with our community nurses, we come across people who haven't had an optimal journey in terms of their leg ulcer management. And often they come to our leg ulcer service, or they come to the district nursing caseload, and they would have had that lower limb wound for some time, either treating themselves or not having the right treatment. So in Betty's story, she's a 74-year-old lady living on her own. She's got arthritis in her knees. She's overweight, but otherwise she's well. She sustains a graze to her leg, which she self-manages for 5 weeks before seeking help. She goes to see her GP, who puts her on antibiotics, gives her some NA dressing supply, and sends her off for further self-care. No improvement, she goes back, and the practice nurse sees her, gives her some more antibiotics, gives her an antimicrobial dressing, refers her on to dermatology. But at no point did anyone do a full lower limb assessment or measure her ankle brachial pressure index, which of course would facilitate a diagnosis of a venous leg ulcer. So the story goes on that it's a long time before Betty gets that right care and gets compression therapy, and all the time the ulcer is getting bigger and her morale and her mood is deteriorating. So it takes 2 years for Betty to heal in that suboptimal pathway. Then the story compares to what would be optimal care for Betty. And of course, on an optimal care pathway, Betty would seek help earlier because she would know that that's available to her. And the practice nurse would have been able to do that full assessment and start compression therapy and work with the local district nurses and tissue viability service to make sure she's on the correct pathway. And in doing so would reduce that human suffering. And in the optimal care pathway, Betty heals in 5 weeks. And my experience of patients coming to our leg ulcer clinics where they get that optimal care is that you can heal some of these ulcers in 5 to 6 weeks. Now, if we look at costs, and of course costs are conversations that we have to have, the suboptimal pathway will cost in the region of £5,500 for that episode of care. But if we do optimal care, it's in the region of £500. So a significant saving that can be made, but also a significant contribution that we can make to improving patients' quality of life if we deliver an optimal care pathway. So Betty's story really highlights those inequalities and variations in care that were highlighted in the Carter report, and particularly so for patients with lower limb wounds, delays in assessments, and failure to implement evidence-based treatments. And we know from the evidence and the high level of evidence that patients with venous leg ulcers will heal with compression therapy. So Betty's story really highlights that if we don't get it right, the outcomes is pretty poor for the patient. Now, I mentioned the National Wound Care Strategy, and I'm really excited to see the publication of the lower limb recommendations for clinical practice. And these recommendations really offer us an opportunity to improve healing rates and reduce patient suffering. The recommendations for clinical care are based on existing evidence and clinical guidelines, and I showed you the SIGN guidelines and the Cochrane review, systematic review for the use of compression therapy. But within these recommendations, they focus on immediate and necessary care, and they talk about red flags, which I'll talk to you more about, and then the importance of getting that diagnosis and treatment right for the patient, and ongoing care and review. So within the guidelines and recommendations, we have this pathway, and I don't expect you to read this busy slide, but I would urge you to go on to the National Wound Care Strategy Programme and to download this document and maybe to start benchmarking your practice to see where you're at. But some patients will no doubt need immediate and necessary care. So I'm thinking about patients who have an episode of infection, so they might have a cellulitis, they might have an acute or chronic limb-threatening ischemia, or you might suspect that they have got a cancerous growth on the leg, so you would need to do something urgent for those patients. Then you've got the wounds on the foot, and we're not focusing on those this evening, we're focusing on the wounds on the leg. And of course, the national strategy recommendations say we must get that diagnosis right, and we must formulate a plan depending on whether it's a venous leg ulcer, whether it's an arterial mixed leg ulcer, and of course picking up on uncertainty. Sometimes you don't know from your assessment, you have some confusion about what might be going on with that patient, and then we need to seek some help and get the multidisciplinary team involved in that patient's care. So there's great opportunities here to improve lower limb care, and I guess opportunities to think about how we can simplify it and get patients involved. So the recommendations say that we should have done a comprehensive patient assessment within 14 days, that we should do a wound assessment, and I think that's really critical in terms of reviewing the patient. So often we don't do wound measurements as a baseline, so then we don't know whether the patient's wound is improving when we go to review them. And then of course really important to do that lower limb assessment, so getting that ABPI measurement done, measuring the patient's ankle circumference, determining the level of edema in the patient's leg. And then we diagnose the cause and we formulate a treatment plan based on what the underlying etiology is. And for many patients, that will be venous leg ulceration, so we need to think about compression therapy. And where possible, patients should be encouraged to think about self-care with support from us as clinicians. And, you know, Jen mentioned the burden of wounds, and that's not reducing, it's growing at 11% per annum. Our workforce isn't growing. And of course, patients have a willingness very often to be involved in their care. So we need to work with our patients to simplify venous leg ulcer care for them. And with that in mind, in East London Foundation Trust, where I work, we've been using a model to promote self-care for some patients over a period of time now. And we've recently written up this work. And from doing the research around transformating care and opportunities for self-care, national surveys tell us that more than 40% of patients want to be more involved in decisions about their care. So again, that willingness from patients, and 40% of patients living with a long-term condition want more support to manage their health. So I think we have to invest time with patients, because lower limb leg ulcers, venous leg ulcers, are really a long-term condition, because even though you heal them, many of those ulcers reoccur if patients are not on a good prevention pathway. So think about how we can invest time with patients that would pay off in terms of supported self-management. But I think not all patients are suitable for self-care. And I think in the COVID-19 pandemic, we have to be mindful to make sure we triage the right patients onto the supported self-care pathway. So it's important with this in mind, and when you're triaging your patients, to consider the complexity of the patient and the complexity of the patient's ulcer. So you also have to think about patients' willingness to participate in self-care and what support they might need. So we have to think about things like capacity, patients giving informed consent, think about patients' dexterity and mobility, and then think about their family support and who within the household might be able to help them with hosiery application, for example, or applying wraps. And then the other thing in terms of the wound itself, thinking about how large the wound is. And here you've got a patient who's got a very large wound, they've got a significant amount of edema, risk of infection with patients like this. So it may be that they're not the ideal patient to put onto a supported self-care pathway. And then the other patients that I would be thinking about are patients who've got a lot of edema in the lower leg, that we would put those patients into compression bandages in the first instance to reduce the edema, and then maybe we can move them onto a self-care pathway. So it's quite a fluid type of involvement for the patient. Sometimes they'll go onto a self-care pathway. It might be that they deteriorate and come back in to having more support in a clinic environment, or you're seeing them in the house. So what we use as a support in terms of helping us make the decision is simple and complex venous leg ulcer pathways. And they were published in this consensus document in 2015 that talked about simplifying venous leg ulcers. And it's a good resource to help you on your journey from our discussions today. So patients who have simple venous leg ulcers are patients who have small ulcers present for a shorter duration of time, and are unlikely to experience complexities. So they're the patients that we would put into a self-care model if they were willing and able to do that. And then on the other side, you've got the complex venous leg ulcers, which are these large ulcers. Often these patients have had them for a long time, and they have multiple comorbidities, and they're unable to be involved in the self-care. But of course, you can have a complex venous leg ulcer and be willing to be involved in your care. So we do need, as I say, to be quite fluid and quite tailor-make it, if you like, on each individual patient assessment. But it is a guide that will help us. Now, at some point on your screen, you will see a poll question, and it will ask you what your preferred compression therapy is, or what compression therapy systems you use mostly. And the choice will be that you use 4-layer, 2-layer, hosiery kits or wraps. And when you see that poll question, just put your answer in, and we will revisit it when we come to doing the discussions later in the session. But let me now show you some examples of supported self-care in practice, and that simple venous leg ulcer pathway that we use in East London. And this is Miss J. The name's obviously anonymised from the patient perspective, but she has agreed for her images to be used for educational purposes. She's a 20-year-old lady who presented with an ulcer in her lower leg. You know, it's very sad and tragic when young patients come in and say, I had my first ulcer when I was 16 years old. And very often they haven't had the right treatment over their period of leg ulceration. She also had a sister of a similar age, I think there was 18 months between them, who'd suffered periodically from a leg ulcer. We did a full leg ulcer assessment. Her indication was that she had a venous leg ulcer. Her ankle brachial pressure index was 1.1 on both legs. So based on her clinical signs and symptoms, her history and her ABPI reading, we made a diagnosis of a venous leg ulcer, and we put her on the simple venous leg ulcer pathway, applying a silicone foam dressing, and of course referring her to vascular services for duplex scanning to see her suitability for venous surgery, because many of these patients can have venous ablation. So on the simple venous leg ulcer pathway, we're applied biotin, silicone foam dressing, and compression hosiery, and she was able to apply and remove that herself. She was able to shower with the dressing in place, and we do some education and invest some time with her in terms of skin management and what red flags for her that would prompt her to give us a call. And she was followed up virtually and she healed in 6 weeks. And then we put our patients onto prevention pathways. We have passports we give to patients and we bring them back to our prevention clinic. So we do have a system to try and reduce the frequency of recurrence. So a good outcome for this patient, and she continues to remain healed. Here we've got another patient, a 63-year-old gentleman, referred again to our lower limb service. He had a history of diabetes and arthritis. He was known to the service. He presented with a recurrent ulcer in his right leg. Because he's known to us, he was able to get himself referred back quickly because he knows that service is there. Sometimes patients are not aware of what's in their area, and of course ulcers can deteriorate and that delays the patient getting the right care. So again, with this gentleman, we did a full leg ulcer assessment, and I think it's really important that you do a full leg ulcer assessment for every patient presenting with a new ulcer. So even though he had a history of previous venous leg ulceration, you start from scratch and you do that full assessment again. We don't make any assumptions that it's another venous leg ulcer. ABPI 0.98 on the right and 1 on the left. His diabetes was well controlled. So again, this gentleman was put into the simple venous leg ulcer pathway. A biotin silicone foam dressing was applied to the wound, and he had a compression hosiery kit. And the fact that he'd had a second episode or recurrence of his leg ulcer means that he does need to have good compression to get this healed and to keep it healed. Again, we do an education program with these patients and give them information. We give them both verbal and written information to enable supported self-care. And he was followed up virtually and he healed in 4 weeks. So, you know, I guess the message is get them in quickly, get them in when the ulcers are small, enable them to do self-care where possible, and get them healed. And then think about how you prevent recurrence. And that's really, really crucial. The journey doesn't end when you get the wound healed. So in conclusion from my section, I guess really what I'd like to say is that the recent advances in technologies allow for a wider selection of dressings, compression therapy garments and devices that really offer patients a much greater opportunity to self-care or to share care with your support. And I'd like to hand back over to Jen now, who's going to talk more about what supported self-care looks like from her project that she's been involved in, and what Coloplast can offer in terms of support for you on your journey to support your patients. But I will be back at the end of the presentations for question and answers. So thank you very much for listening.
That's brilliant. Thank you, Caroline. Some really great insights there around the National Wound Care Guidance and also the patient case studies. And obviously that this simple venous leg ulcers in your clinics can be managed either by the patients themselves or certainly that shared care approach. I actually have another patient here that I'd like to talk to you about, and that's Norma. Norma was a venous leg ulcer patient who worked with Coloplast, and actually Norma highlighted that one of the biggest impacts to her was when she started her treatment for her venous leg ulcer. She started in a 4-layer compression system, which meant that she was really restricted in her day-to-day life, and she found that she couldn't drive anymore. She couldn't go out and visit family and friends, and found it actually very difficult to get to her GP surgery for her appointments. So something needed to change for Norma, and as well as manage her exudate, she needed to be able to manage the wound herself. And she was very much somebody who wanted to get involved with her care and wanted to share in the management of her venous leg ulcer. So Norma was somebody who used a biotane silicone with 3D fit technology underneath her compression hosiery system. And again, in a similar way as the patients that you've mentioned, Caroline, have done. And that meant that she could get back to her normal activities of daily living. It meant that she could shower, for example. It meant that she could get in her car and drive and go and see family and friends and get to any appointments that she needed to. So it made a huge difference to her life and a huge difference to quality of life. But in order to actually self-manage, she needed to manage the exudate levels as well. And she needed to manage the gap. Now, some of you watching may have heard of the gap being mentioned before, and it has been quite widely documented. And I just want to highlight that when we're talking about the gap, we're talking about the gap between the wound itself, the wound bed, and whichever dressing we apply. And not all dressings are the same. Not all dressings will conform to that wound bed. So if that doesn't happen and you have this gap, you can end up with exudate pooling, which then leads to maceration to the peri-wound skin if you get that leakage of exudate, or it could lead to proliferation of bacteria and causes infection. So it's really important that we can manage that gap even under compression with a simple dressing that will enable our patients to help share or self-care. So actually I'd like to now just show you a little video of how that can work in practice.
During wound healing, serum and white blood cells move to the site of injury, which creates exudate that starts to pool in the wound. Managing this exudate is important to reduce risk of leakage and maceration and optimize healing conditions. Even in shallow wounds, a gap between the dressing and the wound bed allows for exudate starting to pool. Excess exudate may leak onto the wound edge and the peri-wound skin, which can cause maceration of healthy tissue, leading to delayed wound healing. This environment could also promote bacterial growth, increasing the risk of infection. Biotane silicone with the unique 3D fit technology is the ideal solution to reduce exudate pooling. When in contact with exudate, the dressing expands and conforms to the wound bed to fill the gap and absorbs vertically to reduce risk of leakage and maceration. Additionally, biotane silicone retains exudate and 99.98% of bacteria. Biotane silicone conforms to the wound bed, absorbs exudate vertically, and retains bacteria and exudate for optimal wound healing conditions. Biotane silicone with 3D fit technology ensures optimal exudate management, minimizes leakage, and reduces the risk of maceration and infection.
Okay, so hopefully that video has shown you what 3D fit technology can do and how that can help to manage exudate and prevent any peri-wound maceration and prevent that knock-on effect and that pain to the patient associated with poor exudate management. Now, this picture here, I'd like you to actually look and see the dressing coming off of a wound, which isn't something that we necessarily always pay attention to. But actually what this shows is that the Biotane Silicone 3D Fit technology has conformed to the wound bed, filling all of those nooks and crannies and the irregular wound bed topography. It also shows that actually the vertical absorption of exudate, so it's been retained within that same area of the wound, creating a moist wound healing environment, but managing the exudate levels so that you don't get that leakage and maceration onto the peri-wound skin. You're also not getting the bacteria proliferating within the exudate, sitting and that's pooling potentially in a wound bed if a conventional foam dressing is used. So this means that it's a simple approach for patients. You're not having multiple layers of dressings underneath compression hosiery, but you can be confident actually that you can use just one dressing, which the patient can change themselves and self-manage in order to fill that gap, manage your wound exudate, and create an optimum healing environment. And quite a few people ask if it can be used with compression. Now, the answer to that simply is yes, it can. And actually, Biotane Silicone with 3D Fit technology shows that in independent testing, it actually handles fluid under retention incredibly well. And it has the highest total fluid handling capacity of all foam silicones available. It also has the unique 3D Fit technology that other foam dressings don't have. So you can be sure that actually you can use this under compression and it will still retain the exudate and vertically absorb, meaning that you don't get that maceration to the peri-wound skin and the knock-on effect that can then have to your patient. And certainly this is what Norma had used underneath her compression hosiery system, and it meant that she got her independence back. It meant that she could go and visit her family. It meant that she could go to the appointments and that she wasn't in pain from maceration to the peri-wound skin. So in simple answers, yes, it is suitable. And Norma herself actually highlighted that it was an excellent dressing and it was so easy to use. And it really did give her the independence back that she needed. So I guess in conclusion from this section of the presentation, simplicity. And Caroline has alluded to this in her presentation as well, that actually by simplifying the approach that we take with patients, it means that they can be involved in their care. And it means that we can look at how we can support them to support themselves, which we really need to be doing. At the beginning of the presentation, I obviously mentioned the decrease in numbers of staff and the increase in wound prevalence. So something really does have to change, and this is a way that we can do that. I'd like to go on actually to talk to you now about some opportunities for self and shared care that were taken up by the Midlands Partnership Foundation Trust. And what they found was that over the period of time that they did this self and shared care programme, that 50% of their caseload was suitable for self or shared care. Now that's a huge number, 50% of your caseload. If you imagine at the moment 50% of your caseload being able to self-manage, so that frees up a lot of your time. And actually that equated to 23 weeks of nursing time per year for the Midlands Partnership Foundation Trust. Now, I know from my own practice, if I'd have had a little more time to spend with the people that really needed it the most, then a huge difference could have been made to their lives as well. So if we could potentially free up that amount of time within all of our caseloads, then think what we could do with that time. And it might be that you only see wound care patients, but it's probably that you see a whole multitude of patients with different problems. So by freeing up some time to be able to spend with the people that need it the most, it can only be a positive. And that's a huge number of patients that are able to self-manage or share in their care. So it's looking at things from a different approach. And really, we at Coloplast can support with this, and if you want any of the materials that you can see on your screen at the moment, whether that's pathways or shared care opportunities and things like that, then by all means feel free to reach out to a member of your Coloplast team, or go to the website for more information. But I'd like to just, in summary, say that transformation of wound care can be simple, and really we need to be thinking about how we can simplify things to be able to support our wound care patients moving forward. And I think now I'd just like to take the chance again to say thank you to Dr. Caroline Dowsett for joining us this evening and giving her real insights into where we're currently at. But I'm going to pass over now to Alec, I believe, and we'll be going to our question and answers session.
Thank you, Jen, and thank you, Caroline. Fantastic presentation. So I'm going to move straight on to the Q&A, because you've had quite a few of them come through, and I've also got the results of the poll as well. But I thought we'll take one. Perhaps we'll address the poll first, and then move on to the Q&A. So the question we put out was, what is your preferred compression therapy? And the results were 4-layer was 14%, 2-layer 53%, hosiery kits 21%, and wraps were 13%. And that was just about 175 people or so replied. One of the interesting comments that I picked up on as well, actually, somebody had put that the 4-layer, which 14% of people said that they preferred. They said that it was too time consuming and it was difficult on their knees and back. So I'm assuming that's the sort of the position that you're in when you're applying it, which I think is a valid point, isn't it? It's do those results match up maybe with what you were thinking? Is that any big surprises there?
I guess from my perspective, if I may, Jen, answer, I guess from my perspective, we've moved in our journey, and it's good to see that people are moving towards less complex systems of application. So it's obviously less time consuming and less energy to apply 2 layers versus 4 layers. And it's good to see that people are using hosiery kits and wraps as well. So I guess I'm pleased to see that people are moving with progress and that they're offering patients choice. Because I think the problem often is that we do what we know and what we've always done, and we'll never transform practice if we do what we've always done. So it's good to see that's moving in the right direction. But of course, we don't know your patients that you're caring for here tonight. And of course, whether you choose bandages or wraps will depend on the complexity of the patient.
Yeah, I would echo exactly what you said there, Caroline. I know that ideally we'd see more of a shift towards the wraps and hosiery kits, because that does mean that patients can help to self-manage, and we've obviously highlighted this evening the importance of that moving forward. But again, you're right, it comes down to that patient assessment and what's most appropriate for them. But I think it's time for us to almost think outside of the box and outside of our comfort zones as well, because as you said, it's what we're used to as clinicians, and that's not necessarily what's always best for your patient. So it's to just be mindful of that, I would say.
And I think as well, a very good point is made by our audience in terms of manual handling risk and the risks to injury when nurses have heavy caseloads in the community setting. And we must do risk assessments, and there are tools and there are packages that we can help to reduce the risk of injury. So stools that people can take out, and of course, try to get patients into positions where you're not having to kneel down on the floor to do their wound care treatment. And I know it's complex if you've got somebody housebound with bilateral leg ulceration, but it's also about doing that risk assessment and raising it within your organisation that there's a risk in managing that patient, and what can we do to reduce that risk.
Yeah, that's a good point. Jen, you mentioned as well earlier about dressings and being able to put dressings under compression. Is that and are you talking about all compression, as in whether it's 4-layer, 2-layer kits or wraps? So there's no issue in using dressings under any of those variations of compression.
I think it depends on the dressing, but certainly, I'm here from a Coloplast perspective at the moment, and actually any of the 3D Fit range can be used under compression. So from that point of view, it doesn't matter whether it's hosiery, wraps, or bandages. It can still be used under compression.
Excellent. So we'll move on to the questions from the audience, because there's quite a few of them. The first one is for you, Caroline, and this is, how many patients on your caseload have the potential to manage their own wounds?
Very good question. Thank you for posing the question. And I'd like to say the answer is it depends, which it usually does. And Jen quoted 50% in the McDonald study that's recently been published from that group. I wouldn't say it's possibly as high as 50% on our caseload, but it does depend month by month, depending on the patients that come into the system. And it really depends on the patient's ability to self-care, their willingness to self-care, the type of ulcer that they've presented with, whether it's complex or simple, and their progress over time. So it might be that a patient starts off in compression bandages and coming to clinic every week, but within 3 weeks they're into the simple pathway where they can manage themselves. So they can, I think it's fluid, they can move between the two. So I would say it's probably about 30% right now. So having a look in preparation for tonight, having a look at our caseload and the new admissions onto the caseload, I'd say it sits around 30%, but it will vary. And we must remember that you might put somebody on a self-care pathway or supported self-care pathway, but if they develop a problem, they could come back into requiring you to see them more frequently.
Yeah. Anything you want to add, Jen, in your experience?
I would agree. It's just that step up, step down approach almost, and sometimes patients will be suitable, and at other times maybe not. So it all comes down to our assessment.
Okay, thank you for that question. Question number 2 is from Heather, and this is, if the patient is able, would you encourage secondary care providers to enable patients to self-care in hospital? I'll ask you both, but if we start with you, Caroline.
Yeah. You know, it's a big issue sometimes when patients are admitted into hospital and they go in compression bandages. Now, I know that people recording pressure injuries on admission very often are obliged to take the bandages down because they want to check the heels to make sure there's no injury in terms of pressure damage. But what sometimes happens is the patient then doesn't get the compression put back on because there aren't people in that setting that do it all the time, or there aren't bandages available. So it could be that the patient's treatment is interrupted. Now, I'm very fortunate to work with that acute care colleagues that have the skills to apply compression. So generally, I don't see that happening very much. So I don't know if that's your experience, Jen, but it is a risk, isn't it, that patients get taken out of compression?
It definitely is. And actually the area that I've come from, when a patient was admitted in compression bandages, they were taken out of the bandages for that very reason, to check the skin for any pressure damage. And then unfortunately, the patients in the area that I have come from didn't go back into compression. They were using methods like leg elevation and keeping the patient in bed. So I think it varies across trusts, and I think it's something that we need to be aware of. And if patients were able to self-manage and they did have their compression hosiery or wraps with them, then it would mean that actually that could continue whilst they were an inpatient. Or certainly maybe the hospital staff that aren't skilled with compression bandages could help support with application of wraps or hosiery. So I think that simplified approach again can help clinicians as well as patients in that environment.
Yeah, hopefully that answers the question. Thank you. Question number 3, this is for Jen. Are patients with signs of infection suitable for supported self-care?
Caroline's spoken this evening about simple and complex venous leg ulcers, and I know that sometimes infected wounds are classed as complex. I would, however, question whether all infected leg ulcers would need to be seen by a clinician. I think some can be self-managed, but again, it comes down to that assessment and also which dressing you're using, and the red flags, and whether the patient is aware of the red flags and what they should be looking out for. But certainly for a localized infection, if it's treated appropriately, with a dressing that can help to manage the bacterial load, and they're having regular review, whether that's virtually or whether that's in person, I don't see why they can't self-manage in between those reviews. Caroline, have you got anything that you would add to that?
I absolutely agree, Jen. I think you've answered that the same as I would. But I think what we need to be doing when we're inviting patients to self-care or to care with support is to tell them what to look out for. So, you know, infection is based on clinical signs and symptoms. So we need to be telling the patient, if your leg feels uncomfortable, you get sudden pain, or you've got more exudate or leakage coming from the wound, then you need to give us a ring. So I think they can continue to self-care, but they do need help to get on top of that infection so it doesn't become a spreading infection or a cellulitis. So I think it's all in educating the patient about what are the things they need to look out for, that they would escalate back to us quite promptly. And then we would see them, we would get them in to treat that local infection, and continue to let them manage their ulcer during that period.
Okay. Question number 5 is from John, and this is why do practice nurses not do ABPI? Caroline?
Yeah. You know, where I work, we have, largely speaking, our practice nurses don't do a lot of lower limb care because we've got 5 clinics a week, so the GPs tend to refer into us. So I think circumstances vary across the UK, but the thing with practice nursing is they have 10-minute appointments, and you can't do a full holistic leg ulcer or lower limb assessment within 10 minutes. So often they have to give patients 2 or 3 appointments. Now that's one issue, is that the appointments they have on offer are short appointments. The other issue is that there's no enhanced payment for GP practices around leg wounds or wound care. So they don't get paid like they do for the flu vaccine or doing blood pressure checks. So that is a bit of a barrier in general practice to them embracing lower limb care. So time's one issue, and money not following the patient is another concern, I would imagine. I don't know what you think, Jen, whether you've got any insights that I've failed to.
I actually worked as a practice nurse for a little while, and because I was able to do ABPI assessment, I did find myself running clinics a couple of times a week to be able to help manage some of those patients. So in the area I was in, I was given more time to be able to do that, but then we didn't have any local leg ulcer clinics to manage those patients, so they were all managed within practice nurse settings. I think it varies, as you say, across areas as to how those patients are managed and whether practice nurses can do those assessments or not. And it all comes down to the education of the practice nurse themselves, I guess.
Yep. Question number 6, this is from Sheila for Caroline. What happens at your prevention clinic? And also, how do you undertake virtual follow-up, i.e. what resources do you need?
Yeah. So let me answer the first part of the question. So we learned very, very early on when we set up our leg ulcer clinics that recurrence rates were high. So we got patients healed, we put them into compression hosiery, and we were finding those patients were coming back within the 6-month period post-healing. So we knew that something different had to be done. So we actually set up these prevention clinics. So what happens is we recall patients, we do the ABPI check, we do the skin checks, and we issue them with new hosiery, and then we send them on their way again. More recently, we've designed patient passports, which the patient carries with them, and on the passport it says when they had their assessment, what their ABPI was, what hosiery they're in, and how to contact if they've got a problem. So it's been great in terms of we published our results a few years back, and we were able to take our recurrence rates right down to about 5%. and recurrence rates can be 70%. Now, I don't know exactly what they are at the moment. We audit them periodically, but it's a great way of keeping patients in the system, if you like, by having a recall so we get them back in. Now, that's the first part of the question. The second part of the question, remind me, because I've got carried away answering the first bit.
So how do you undertake the virtual follow-up, as in, and what resources do you need?
Okay, so I think we've got much better at the virtual platform with COVID-19. So I have to give credit to the wonderful team that I work in, and I can see them. They're on their iPads and they're actually in the house with the district nurse and with the patient, talking to the patient, talking to the district nurse. The district nurse is zooming in on the iPad to show the wound to the tissue viability nurse. So we use that platform, but we're very lucky that our community nurses have that facility. So they have iPads, they do their lists on there, they can do their notes on there, their EMIS is on their iPad. So I think if you're progressive in your organization with technologies, then those virtual follow-ups are easier to do. Sometimes patients ring us in on their phones, so on FaceTime or whatever they need to do, whatever works for the patient. But from the purpose of follow-ups with the district nurses, rather than two people going into the house, we'll do it on a virtual platform.
Yeah, okay, thank you. I mean, I guess your point is around the individual trusts that these people work for, whether whether they're sort of up to date with the technology side of things, and whether they provide those sort of tablets and that sort of thing. It's probably worth checking with your trust, I guess, if you're not sure whether you have those things available. There's probably someone that you can check with. Question 7 from John. This is: ABPI equipment is pricey. Is there any reason why people don't use pulse oximeters? Either one of you want to answer this? There's a question.
Shall I take it?
Yeah.
I guess the recommendation is that you do an ankle brachial pressure index. And a pulse oximetry isn't going to give you that calculation. So if we look at the recommendations from the National Wound Care Strategy and from all the clinical guidelines on leg ulcer management, it says that we shouldn't palpate pulses, we should do that full ABPI. It is an expensive piece of kit, but I think if you think about general practice, sometimes they have Dopplers there for doing maternity care. You just need to have a different head for the Doppler. So I think it's about maybe multi-use for the main piece of the equipment. And of course, now we're moving over to automated devices that can give us results very, very quickly. You don't have to rest patients for quite so long. But I think, if the evidence is telling us and the guidelines tell us that we have to do this for the patient, then our trusts have and our organizations have to fund that equipment, if that's what is needed for the patient. And of course, it's not a one-off use. We use it on all patients with lower limb wounds as part of assessment. Don't know what your thoughts are, Jim.
I agree, and I would also think about the cost of the patient's treatment if you're not treating them appropriately, having done an ABPI assessment. So actually that's going to prolong treatment, which is then going to have a knock-on effect to the cost of treatment. So if they're not cared for in an optimal way, which is what we've shown with Betty's story this evening, then you're going to increase costs anyway. So if you need that fundamental piece of equipment to be able to do that, then the trust should be providing it.
Yeah, I've actually seen Dopplers made. It's a fascinating process. They're really quite complex, actually. And your point, Jenna, is around the sort of cost of treatment. If you don't do the ABPI. There's lots of companies that have these devices that can measure ABPI. And for John, I'd say check them out, because we're not here to promote any of them, but check them out, because they each of them will offer sort of business cases that they can provide you with to show that, yes, it might be a fairly expensive single outlay, but you'll get the money back in spades if you treat your patient well. And obviously, Caroline and Jen have been stating quite clearly today, you really do need to do an ABPI. So question number 8, this is from Jackie. This is: how do you feel about care staff completing the dressing on behalf of the patient? Jen, for you first.
Yeah, I mean, I don't see a problem with that. Again, as long as the care staff know the red flags to look out for and potential risk of infection and those sorts of things, there's no difference in a member of care staff doing that dressing change for somebody than the patient doing it for themselves. So if the patient doesn't have the dexterity in their hands, for example, then there's no reason that a carer couldn't do that dressing change for them, as long as they have consent to do so. So yeah, I mean, I don't see that as a barrier, to be honest. Caroline, do you have anything to add to that?
I think we absolutely welcome care staff, both formal and informal, to be involved in lower limb care. And when we talk about that simplification of patients going into wraps and hosiery, then I think there's an even greater opportunity for care staff to be part of that patient's treatment pathway.
And there's no issue with the healthcare professional who does the initial assessment and decides on what the treatment is going to be, talking directly with the carer, whether that's an employed carer or a family member, to actually tell them what they need to do, rather than telling the patient and expecting the patient to then tell the carer.
No, I think if the member of staff that's done the assessment and has chosen that treatment plan, if you like, in conjunction with the patient, if the care staff are there at the time as well, then it's good to have the discussions with them, as long as the patient's happy for you to do so. If they're going to be helping to manage that patient, then they need to be aware of why you're choosing what you're choosing and what you're trying to do in order to help support that patient. So yeah, education is key.
Yeah, thank you. So question number 9, this is from Debbie. This is even if self-caring, should they still have regular checks with an HCP? Caroline, I think you mentioned it. I think you touched on this a bit earlier, so I'll hand this over to you.
So I think we've got to remember where the accountability lies. And as a healthcare professional, if you've got a patient on your caseload, whatever their treatment pathway is, that's still your responsibility. So it's up to us as healthcare professionals to make sure that that patient is on the right pathway, for starters, and then that they're supported, and if there's any concerns, that we deal with those concerns. So I think review is really important, and that can be face-to-face review or virtual review. But I think the important thing when you've got patients on this pathway is having that therapeutic relationship, so that you pick up if there's any anxieties in the patients, because patients really don't want to be a burden to healthcare professionals, and sometimes they'll say they're okay, but if you've got a good relationship with them, you know that there's a bit of an issue, and you can sort of tease that out in the virtual review, and then that might prompt you to go and see that patient. So the relationship's really important, and that review is crucial.
Good, thank you. Jen, do you want to add anything to that? I think we're probably coming up to our final question. Yeah, I think we're going to leave it there. Jen, Caroline, thank you again for a wonderful presentation. For the audience who have joined us this evening, thank you very much. As I said at the start, it would be very little point in us putting on these educational events if you didn't join us every time. So we thank you very much for that. And to Coloplast, who have supported this event, thank you very much. We certainly look forward to delivering more content with you in 2021. There should be some links on the screen now to download your certificate. I'm going to be slightly self-indulgent just at this moment and just thank my team and the team at Mole Digital, who throughout this year and throughout the pandemic have delivered, I wouldn't even like to guess how many of these events. So thank you very much for all of your hard work. Please have a fantastic Christmas, a wonderful New Year. Stay safe. Do whatever you need to do to stay safe first and foremost. We'll be back in the new year. Keep an eye out. I think our first event back is towards the end of January. So I think that's it. So I'm just going to say again, Happy Christmas, Happy New Year, and we look forward to welcoming you back in 2021. Thank you and good night.